So, Bismillahirrahmanirrahim. Professor Mustasir Saab has discussed in details different aspects of fat grafting. Sir has discussed even how to take and how to process and how to inject. So, now I will specifically discuss nano fat grafting. So, just going back into the history of fat grafting, first fat grafting procedure dates back to 1893 when a German plastic surgeon transferred fat from arm to the orbital area. Only 2 years later, in 1895, Dr. Victor Cherney transferred a lipoma to the breast to establish symmetry following a unilateral partial mastectomy. However, over the next 100 years, this fat grafting has trouble in acceptance due to complications associated with this fat grafting. However, in 1990s, Dr. Sidney Coleman, he started publishing papers on fat grafting, and he described standardized techniques for fat extraction, processing and injection. So after that, actually, procedure's popularity has only increased along with wide variety of applications. So after that, plastic surgeons and other clinicians, they started thinking on the application of adipose tissue, stem cells. In 2001, a group of plastic surgeons and researchers from University of Pittsburgh published a paper in Tissue Engineering describing applications of adipose tissue in cell-based regenerative therapy. Since 2010, that is the area after that we are more involved in stem cells, we have began to learn how to unlock the regenerative potential of adipose tissue. So, term nanofat was first used by Tornard et al. In 2013, and he told us that it can easily be used for skin rejuvenation due to its small size and the fact that it contains many abundant stem cells. So, nanofat grafting may open possibilities of adipose tissue as a primary source of mesenchymal stem cells, very rich source of stem cells, and SVF in biocellular therapies in future. So before starting our nanofat, discussing nanofat procedure, just I want to describe these terms. So nanofat actually does not contain any fat cells. We process it in a way that there is no stem cell, there is no fat cell. Only it contains stem cells. And micro fat grafting, in which the size of the particle is less than 1.2 millimeter. So that is called micro fat grafting. And milli is between 1.2 to 2.4. If the particle size, fat particle size is between 1.2 to 2.4, then it's milli fat grafting. And macro fat grafting is greater than 2.4. So nanofat, we will discuss where we can inject, and microfat mostly we inject in delicate areas on the face, superficial, around the eyes, and milli also, but the particle size is larger as compared to micro, so we inject in the deeper compartments of the face and other parts of the body. And macro we inject, as we discussed early in the morning, we inject in breast and buttocks and other parts of the body. So coming to the procedure of this nanofat grafting, so it involves basically 3 steps: extraction of the fat from the donor area with liposuction, and then processing, and then re-injection of this purified fat into the area where we want to inject. So nanofat grafting procedure, as we need only maybe 10 to 15 cc fat, so we perform in local anesthesia, and following aseptic measures should be done, I think, in theaters. to avoid any infection. Fat is aspirated from the most superficial level to recover the maximum stem cells. And as we discussed in the morning, we liposuck from medial thigh, lateral thigh, inner part of the knee, lower abdomen. And we mostly do get this fat from abdomen mostly. And infiltration, before this liposuction, we infiltrate actually this local anesthesia that contains ringer lactate, adrenaline and xylocaine. So routinely in the liposuctions we use this composition of local anesthesia. In 1 liter of ringer lactate we add 1 adrenaline and 2 ampules of xylocaine, 2%. However, as we need only small amount of fat, maybe 30 cc, mostly we get 40 cc, 50 cc for this nano grafting procedure. So this is a combination composition of the local anesthesia fluid we use. We use 200 ml of this ringer lactate. We add the same 2 ampules of 10 cc, 2% xylocaine, and 1 ampule of injection adrenaline. So that will make 1 into 200,000 dilution of adrenaline, 2 milligram per ml of this xylocaine, and that is safe. And we are routinely following this protocol. So once you have injected that local anesthesia and you have done a little bit tumescence, we can wait a few minutes, and we routinely wait for 5 to 7 minutes. Let this local anesthesia to act, and also this adrenaline. And adrenaline will cause vasoconstriction, so it will reduce the bleeding as well as it will increase the time of anesthesia. So here microcannula is mentioned. No doubt ideal is this to get with microcannula, but you can also use other cannulas as well, because ultimately you have to destroy the cells, so it will be nanofat. So microcannula, that is 0.7 to 0.9 mm, is connected to a 10 cc Luer-Lok syringe, and small adipocyte globules are harvested under the. So you maintain pressure, negative pressure with this 10 cc syringe. You connect the cannula, we will demonstrate tomorrow, with this 10 cc syringe, and maintain with the plunger negative pressure, and then you liposuck. And what we routinely use this 2 mm, 1.5 or 2 mm cannula. It is easy to liposuck, otherwise it will take a long time, maybe 1 hour if you suck with this 0.7 mm cannula. So several methods have been described for processing this harvested fat, including Carter's gauze rolling, centrifugation, gravity segmentation, and to effectively remove the infiltrated anesthetic solution and cell damage. So here what we follow, mostly we follow this gravity segmentation. We just keep it there for 5 to 10 minutes, and all the components are separated. So I will show you the picture later on, how we will separate and what are the components layer wise. So the best method of this, out of these 4 methods, still controversial and still discussions going on. Most debate concern whether centrifugation of lipoaspirate is necessary for graft survival or not. But still discussion. But what we are using, we just separating the components with this gravity segmentation. So this filtered microfat is then transferred into 10 cc syringe and mechanically emulsified. Emulsification of fat is achieved vigorously shifting the microfat between 2 10 cc syringes. So microfat connected to each other by a purple 2.4 diameter Luer-Lok connector. So with the help of this connector, so these are the connectors. So we connect 2 10 cc syringes with the help of this connector. Upper one is 2.4 mm and lower one is 1.2 mm. And this is how we pass fat from one syringe to the other syringe. And we standardly you follow is 30 passes. After 30 passes, there are one or two studies, and they have seen under microscope that there is no viable adipocytes even after 30 passes. So there is only stem cells. So 30 passes are sufficient sometime, and this author from where I took most of my presentation, he uses 60 passes to make it further refined, and to because he injects it with very fine bore cannula 27 gauge. So that is blocked if we use this 30 protocol. So after 30 passes, fat becomes more liquid and whitish, so its color also changes. This number of passes is arbitrary but has proven to be effective in our experience, and now there are studies that shows that this is effective, and you will not see any fat cell after 30 passes. But this author, he repeats it with the grain connector 1.2 mm and gives 30 more passes. So this ensures that even the most fibrous fat can be emulsified. So he can inject it even with small needles. So what is the end point of this nano fat? You are sure that. So change in color, so it will be more whitish, as well as the other is consistency. So after emulsification process, this fatty liquid is passed through a strainer cartridge with a dual. So it is passed through a filter. This filter to remove any connective tissue remnants. So this is must if you want to inject with this fine 27 gauge needle. So it will not, otherwise it will be very difficult to inject with these small needles. So effluent is the end product, nano fat. It is transferred from 10 cc lower log into 1 cc. This is done by author, and we usually inject with the 10 cc. So that is easy for us. But you can also follow the author. So these are connectors, and this is a filter. And you can see this is microfat, and this is nanofat. So you can see the color change. And this is filter, again filter, and this is being emulsified. So this is how it will be after you have followed this gravity sedimentation. So there are three parts you can see after liposuction. This lipoaspirate, the topmost is oil, fat, and then the fluid you have injected. So you have to separate all these three components separately. So just I added this slide to show that whether it is macro fat, milli or micro or nano, it contains the same amount of stem cells. Stem cell उनमें भी हैं जो माइक्रो और मिली है. So what next? So once he has filled 1 cc syringes with the nano fat, so he injects actually with the 25 gauge cannula, and through 4. This is for face. So he follows 4 entry points: orbital area, 1 point, cheek, jawline, temporal, and 1 cc, 1 ml in each area. He injects. So this is author's protocol, 5-6 cc on each side. This is nano fat. There is another publication, and we routinely follow. We mix it with micro fat, and we add 15 cc on each side of the face. So coming to the mechanism of action, nano fat grafting, as I think we discussed already. So nano fat increases the vascularization, new collagenesis, tissue regeneration, and also improves skin physiology. So in particular, adipocyte-derived stem cells play a vital role in skin rejuvenation, although their multipotent nature may not be the only advantage, as we discussed in previous presentations. So adipose-derived stem cell also secrete, very important point, many stimulatory factors such as cytokines, chemotactic factors, extracellular remodelers, growth factors, and their inhibitors. So these factors are capable of very complex functions involving several bioactive factors. So ASCC, adipose tissue derived stem cell, not only help in skin regeneration but also in repair of nanofat. So very important point, nanofat is not a filler. So hardly any viable adipose. So when you are injecting on the face, so it will not give any volume, maybe 1 week, 2 weeks. After that there will be no volume. So it will provide only stem cells. So sometimes we mix it with microfat to add volume to give good results sometimes. So nanofat is applicable in a wide range of indications to improve the skin quality. We will discuss. So there are 3 categories of indication for the use of this nanofat. Most commonly used we use on the face for trophic skin changes caused by age and sun damage. So here nanofat definitely it improves, but still long studies needed how much it will improve. So better is if we can mix with the microfat, it will give the volume, it will improve the fine wrinkles and it will give the glow. And even this microfat is supposed to stay there. So definitely if you will inject only nanofat, so it will not stay there, may not give effect. So even this nanofat single session, microfat single session on the face, usually it stays 20 to 30%, the rest is absorbed. So we have to repeat the sessions. So this is a very important point here. So second condition, pigmentary skin condition as we discussed already. And third is scarring and atrophic skin changes. We are also using in scarring nanofat along with the, if we can use with the microfat, that it will give a good results. We have done few cases with orthopedic people, osteoarthritis, especially the knee, more than 10 cases, and we have got good results in terms of pain control. So maybe more than 90% people, they are happy. And chronic ulcers, good results. Non-healing ulcer, we inject along with PRP sometime, so it gives us a rapid healing. So in plastic surgery, sometimes we do skin grafting with nanofat, so it will increase the take of that graft. And androgenic alopecia, I think most of the people are doing this nanofat in the scalp. So we are also doing, and we have got good result in terms of hair fall and stoppage. Other parameters still we are on these points, like quality of hair, new growth of hair. But definitely more than 95% people after a single session, they have a reduction in the hair fall. And usually we recommend once they are fed up with PRP and they are not happy, so you can recommend them either alone this nanofat or with PRP. So recently this nanofat is integral component of facial rejuvenation strategy, and we should offer to all of his patients. And nanofat areas are non-facial areas such as neck, hands can also greatly benefit. Mostly we are injecting on the dorsum of the hands, and we are getting good results. And better is to inject again with microfat, so that it should little bit volume we need later on to improve the quality of skin. So that will be provided by microfat. So coming to this, because it is a surgical procedure, invasive procedure, so it is not without complications. Luckily we have mostly minor complications, top 5 are edema, chemosis, contour irregularity, deep wrinkles and volume excess. And where you may encounter periorbital lipogranuloma, so can be managed conservatively by observation, by steroids, and sometimes we have to excise it. So more serious complication can also occur, like vision loss, skin necrosis and ptosis. Then we have to act accordingly. We have to vision loss. We have to get consultation of ophthalmologist. So NanoFat technology can likely be expanded to cover indication for hair or genital rejuvenation, and this is already we are doing for hair and for genital rejuvenation as well, along with microfat to give the filling effect as well. So thank you very much. So any